Thank you, Alan. It's a great pleasure to be here. Just like to declare my interests. Okay, so in this lecture, I've focused it towards a more clinical audience. I'd like to introduce to you the new conceptualization of the obsessive-compulsive and related disorders, then discuss with you the first-line treatments, look at health-related quality of life, talk about the need for long-term treatment, and I'd like you to be reflecting, particularly the general psychiatrists among you, about how your services are configured and whether that supports good long-term outcomes in disorders like OCD. Talk a little bit about predicting treatment outcomes. I was very interested in Declan's talk. Of course, we don't have good treatment predictors, but we'd love to have them. And then talk about the management of treatment refractory OCD, because of course that's what we as clinicians tend to be grappling with all the time, and move on to novel targets and treatments. So I'll try and do all this within the time available. So many of you now will be familiar with the new reconceptualization of these obsessive-compulsive and related disorders, OCD, having been plucked from anxiety disorders and sitting at the head of a group of disorders characterized by compulsive behaviors. So we have body dysmorphic disorder, and I'm delighted that my colleague David Veal is going to be talking about that this afternoon, so I'll try not to overlap. Hoarding disorder, again, the general psychiatrists among you, each of us have got one serious hoarder in our patch. And then the hair pullers and the skin pickers, these body-focused repetitive behavior disorders, they tend to hide their symptoms. So I would suggest just look at your patients. Look to see for bald patches, look to see whether they've got a weird hat on their head, covering something up, and look for spots. Women in their 40s with a pockmarked face may well be skin picking. They tend not to talk about it. And if there's any slide that is a takeaway message, I suppose it's this one. We could really stop here. This slide's from a nice book by John Grant, Sam Chamberlain, and Brown Odlow, recently published by Oxford University Press, sort of summarizes the clinical treatment of obsessive-compulsive related disorders. And I've picked out here we have all those disorders, here we have the medications, here we have the psychological treatments, here we have the other, by which I mean somatic treatments, and here we have the pivotal rating scales. And I've picked out in royal blue those treatments for which we have what you might call Class 1A evidence of efficacy. So, and the first thing to point out is OCD has got by far the most data around it. We know very little about the other disorders. And we can see that SSRI, clomipramine, and adjunctive antipsychotic are helpful, as is CBT with ERP. Similar for BDD. BDD looks very like OCD. That's all I'll say about BDD. But then when we move down the grouping, the disorders don't respond in the same way to treatment. Hoarding disorder is very treatment refractory. There's a signal that from open label studies that venlafaxine, which has noradrenergic elements, might work. Hair pulling and skin picking disorder have a very variable response to SSRI. They're probably heterogeneous disorders, but there's also signal that drugs acting on glutamate and dopamine systems and even opiate systems, this idea that these are behavioral addictions, that there's some kind of pleasure in getting the great hair pull, and that an anti-opiate might actually treat that, is actually informing the treatment of all these disorders, particularly the resistant cases. I picked out in blue capsulotomy because those of you who are interested might have seen that there's a nice positive randomized sham-controlled trial of gamma ventral capsulotomy coming from the States, which looked significant, but unfortunately an obsessive reader spotted an error in the data and the paper had to be withdrawn and resubmitted, and significance just got lost in the reanalysis of the data. So I would say the jury, there's a lot of data supporting capsulotomy, but it's still not quite Class 1A evidence. Loads of guidelines cover OCD. They tended in the past to be anxiety disorders guidelines. And I draw your attention to the BAP guideline recently revised in 2014, that includes OCD within it. Also the NICE guideline, which moved away from the anxiety model and included body dysmorphic disorder with OCD. And finally, a new paper coming out in the International Journal of Psychiatry and Clinical Practice from the International College of OC Spectrum Disorders, describing clinical standards of care that are required for treating people with OCD. But what all these guidelines and reviews and consensus statements tend to show is roughly the same thing, that in terms of treatment for OCD, we have behaviour therapy, which involves exposure and response prevention, takes at least 16 hours in vivo. In other words, you can't just talk about it, you've got to do it, and you've got to practice the homework regularly. And pharmacotherapy with serotonin reuptake inhibitors, that's SSRI or clomipramine. Other antidepressants, anxiolytics don't seem to work. Higher doses, extended duration, minimum 12 weeks, and there's a role for adjunctive dopamine antagonists. Probably combining these two works better. We don't have good data. We're just completing a pilot study, which I hope will lead on to the big study needed to really show that is the case. But approximately 40% of our patients fail to respond. Even those who do have a really rather weak response. Relapse is common, and so better treatments are needed. Now, this is the most recent meta-analysis that's come out on OCD. It's one that I happen to be part of. The first author is Petros Skapinakis. And this is a network meta-analysis that tries to compare the relative efficacy and tolerability of all these treatments. It's quite here we have the cat's cradle, the sort of normal picture of these sorts of things. The size of the blob represents the number of patients subjected to the treatment, and the thickness of the line represents the number of studies. So the first thing you can see is there's a lot is placebo. There's a lot of patients who've had pill placebo. A lot of patients have had clomipramine, fluvoxamine, and the SSRIs. What about on the psychological treatments? Well, psychological placebo, which presumably is the fair comparison for CBT, hasn't had many patients going through it. And those studies that have been compared against psychological placebo tend to be the behaviour therapy studies, the ERP studies. Cognitive behaviour therapy has tended to compare itself to WL. What's WL? WL is waitlist. Many of us would think that waitlist is not an ideal comparator for a psychological therapy. So there's a lot to be seen in this cat's cradle of comparisons. The upshot was that along with NICE guidance and the BAP guidance, it looked as though in adults and largely in children, though the numbers of studies in children were far fewer, that SSRI, clomipramine, and behaviour therapies were effective. Most psychotherapy trials included patients who were on medications. Almost all of them did. So that was a major confound. So I think the bottom line is we need better trials, particularly of the psychological treatments, in order to be able to answer the question, which is more effective. Having said that, based on the data, there's pretty convincing evidence that behaviour therapy and cognitive behaviour therapy and these serotonergic drugs do the trick. Out of the NICE guideline, we got this stepped care model for OCD with cases that are more difficult or intransigent to treat, moving up these steps to inpatient cares or inpatient care or intensive treatment programs. And David and I together lead a national OCD treatment service commissioned by NHS England for the most treatment refractory individuals. And you're welcome to refer both of us cases. So one of the questions that was very interesting that came out of the Maudsley and out of their highly specialised services, since we introduced these guidelines, has it had any positive effect on the way patients are being cared for? And this is a study that looked at children with OCD. It's a sort of audit, really. It's just looking at what treatments they had been receiving before the NICE guideline came in 2000, 2002, and then after the NICE guideline came in 2009. And this is actually children. And it said how many of them, this is a service for resistant patients, so you'd expect that they'd have, pretty robust treatment before they came. So before the NICE guideline, about 2/3 of them had had CBT or SSRI, the evidence-based treatment. But after the NICE guideline came in, this had dropped to less than 50%. Meanwhile, the Y-box score, the children's Y-box score, which is the pivotal OCD rating, actually had gone up. And when we look at the breakdown of what treatments have changed, what we see is that children have dropped out of receiving SSRI for no good reason whatsoever. So this is a salutary piece of data suggesting we need to be better at it, because this is essentially why I'm here. What we really need to be following is this idea of research-enhanced healthcare, where we can use the research evidence together with the patient preference and clinical state to really develop our clinical expertise and not neglect our patients. So I'll just run through the clinical pharmacology of obsessive-compulsive disorder very quickly, because some of this will be very well known to you. The first question is, which dose of treatment should we be using? And essentially, we're talking about SSRIs. This is a very nice study that compared two different doses of escitalopram, 10 and 20 milligrams, versus the minimum effective dose of paroxetine, which is 40 milligrams, head-to-head against placebo. And here you see the course of treatment, and you can see that the 20 milligram dose of escitalopram is the darker blue line, and it falls roughly on a par with paroxetine, whereas the 10 milligram dose of escitalopram over the course of, this is a 6-month trial, that talks to the slow progress that OCD patients make and the need to follow them up at least for a few months. Shows that even by the end, this was the primary endpoint, but even by the end of the study, there was clear water between the 10 and 20 milligram escitalopram groups, suggesting that the higher dose was more effective. This slide just looks at people going into a proxy version of remission and showing again that if you stop your study at 12 weeks or 6 weeks, you're missing most of what's happening, that people are going into remission over the course of 6 months. But that even then, even with good prognosis cases, only about 45% have actually achieved some measure of remission. And this slide is simply a systematic review of all the dose-finding studies in OCD that have compared head-to-head different doses against placebo. Here's that escitalopram study I showed you before, and I've picked out in yellow those that had a positive dose effect, and the majority did, suggesting that the higher licensed doses are the most effective. Well, that's all right on Y-box scores, but does this do anything to health-related quality of life? Because arguably that's what we're interested in. This is a bit of a complicated slide, I apologize, but it's different ways of measuring health-related quality of life using, again, another proxy measure, which is the SF36, looking at all these different domains within quality of life. And the dotted line are United States population norms, and these boxes and the filled line are OCD norms at the outset of a treatment trial. And you can see people with OCD of moderate severity fall away from population norms on all these roles of health-related quality of life. In fact, in its most severe form, of course I'm very subjective, these are the sorts of people I treat, its very severe form, it is at least as disabling as schizophrenia. And this is the result of treatment in a study. It happens to be the escitalopram paroxetine study I showed you, looking at exactly those same domains and showing that the effect of treatment has to some extent remediated quality of life deficits in the areas that count. I talked about the issue of combining treatments and the fact that the jury really is out, but most of us in the field believe that you should be combining drug and medication. If we have time, we can discuss why that might be helpful. This is just one study that tried to tease that out, looked at partial responders to SSRI, and then randomized them to adding in placebo or risperidone, which in other studies does seem to show a signal of working in treatment-resistant OCD, but which didn't in this study, and exposure and response prevention. And I've put these details in just to show you what's expected when you give exposure and response prevention. This is what you're expecting your treatments to get. 17 twice weekly, 90-minute sessions, daily homework of at least 1 hour, and between session telephone check-ins. That's what you get in an OCD service in the States. And if you get that and you add it to your SSRI, you do get further improvement in SRI partial responders. But again, just reflect on the services that you might have available and whether that's something you could easily provide to patients. Is there any way of predicting outcomes on an individual basis? Well, one way is to look and see whether they make an early treatment response. Is that going to tell us anything? I showed you that the treatment response in OCD is slow and gradual. That doesn't mean to say it doesn't start early. You just need a lot of patients and a strongly powered study to show the slow, gradual emergence of symptoms over time. And in fact, when you look at those who improve early, so maybe like sort of 20% reduction in Y-box, that early for us is 4 weeks, you find that if they haven't improved at 4 weeks, there's only a very small chance they're actually going to improve over the course of the 12 weeks. So it may give you pause for thought at that point. But then on the other hand, even if you did show a 20% improvement at 4 weeks, there's not a great chance, there's only a 55% chance you're actually going to respond at 12 weeks anyway. So there's a sort of, and there's a law of diminishing returns in terms of switching around treatments. So we really, I suppose the message from today is we really do need different ways of looking at these disorders and treating them. This tells the message really very nicely. It's an American study, and I know David has done his own work, and I'm sorry I didn't give you his slide. But this followed up over 5 years, 213 adults with OCD in a very reputable centre in the OCD centre in the States. And over 5 years, only about 40% of people entered either a partial or a full remission. And full remission is only 16.9%. And remission for us could be something like, patients are still really quite disabled. It's not a total recovery by any stretch of the imagination. Harm-related OCD seemed to do quite well. If you weren't as ill, and if you had a shorter duration of illness, you did better. So that talks to early intervention. Get in early. It means getting in childhood, maybe getting in the womb. Wouldn't that be a nice, novel way of approaching these disorders? And those with hoarding, again, it's no surprise, were much less likely to remit. But here's the rub. If you were in that lucky 40%, the lucky few who'd remitted, followed up over the course of 5 years, there was a 60% chance you were going to relapse. And those with obsessive-compulsive personality disorder, a disorder very close to my heart, many of us in this room will have traits of OCPD. It's great, but it's not that great. If you've got OCPD, you're more than twice as likely to relapse. We think of it as you can stretch an elastic band, but as soon as you let go, it snaps right back. And again, if you only got a partial remission, you were much less likely to do well. Again, talking toward vigorous treatment of this disorder and challenging that stepped care model of giving people wishy-washy treatments. We may wish to turn the pyramid on its head. If you're a child, you seem to do better. So again, arguing for early intervention. Your brain is more flexible, there's more opportunity to do well. Although this child's follow-up study only looked for 3 years, it would be interesting to see if they followed it up for 5 years, whether they did quite as well. Only about a fifth of those cases relapsed. But again, the message is treatment early in the course of illness, early intervention, not only in psychosis, early intervention in compulsive disorders. How long to remain on treatment? Well, this is when we do these relapse prevention trials, assuming that the patient is doing well. If you randomly discontinue the medication and swap them to placebo, you get a much greater fallout rate, much poorer survival over the course of 6 months. This is escitalopram. If you stay on escitalopram, you stay weller. But it's not a panacea. About a quarter of patients on escitalopram relapsed, as opposed to about 50% relapsing over the course of just this study. And here we have a meta-analysis looking at all those relapse prevention studies with the little diamond sitting proud from the line, suggesting that if you remain on your SSRI, you tend to do better than if you discontinue it within the confines of a treatment trial. In fact, I'm not sure that we know a good time to stop. There's no evidence that there's a safe period when you can stop medication. So if a patient is doing well, I tend to recommend they stay on the treatment. And this is why. This is again another sort of pivotal slide. Why? Because this is the effect of relapse on quality of life. Here we have our SF36 and all these domains, general health and vitality and so on and so on. This has nothing to do whether you're on medication or not. This is whether you relapse or not. And if you relapse and you're in the pale grey, you lose quality of life across all these domains. And this is where things happen, like your employers tolerated your treatment with OCD, gave you time for OCD, gave you time off to do the treatment. You went back to work, you relapsed, and they've now had enough, and they think, oh, we invested all that time in you, and you're dismissed. Or your wife walks out on you because she's just, everybody thought you were doing well, and it's all come back, and this is all too much. So relapse really is very disabling. And I think we should do our utmost to try and protect patients against relapse. Okay, but what about those cases who don't do well? Well, we have very little, truthfully, very little to offer. You have your first-line treatment with SSRI. You might, if they fail to respond to that, review the diagnosis. Autistic spectrum disorder, we've already had a wonderful lecture on it. We've surveyed our clinic. 40% of cases scored high on a screener for autistic traits. What that means, we don't really know, but check for it. Attention deficit hyperactivity disorder, very common within this group. Not very good studies, poorly understood. So look at the diagnosis. You may want to switch or go from an SSRI to clomipramine. Again, there's about a 30% chance that you'll respond to a different one. And then we're sort of in terra incognita, really. You could increase the dose beyond formulary limits. You could add in a second-generation antipsychotic, and there probably is now Class 1A evidence for the group as a whole, if you can sort of lump the whole load of antipsychotics together. And then you can go to these more esoteric treatments. I put first-generation antipsychotic here because the side effects are more difficult for OCD patients to tolerate. They get a lot of extrapyramidal side effects, which probably talks to the circuitry that's involved in the disorder. You could try to get intravenous treatments. It's almost impossible. It's now not easy to get intravenous clomipramine in the UK. You have to order it in from abroad. And it usually, in my experience, usually fails terribly in NHS psychiatry. You might want to combine clomipramine and SSRIs. The data supporting this is not very favourable, so I tend not to do that. Sometimes you're trying to moderate side effects. You give a bit of this, a bit of that. You have to be very cautious with those SSRIs that may interact on the hepatic cytochrome P450 systems that affect the metabolism of clomipramine. You don't want to overload your patient and produce toxicity from clomipramine. So I tend not to use that approach. And then there are some novel agents. The data for higher doses is going beyond formulary limits is not great, but there's this randomized controlled trial where people who hadn't responded to 200 milligrams of sertraline were randomized to 400 milligrams or staying on 200 milligrams. And those who went on to 400 milligrams did better, and it was very well tolerated. You have to be cautious now. This is a nice slide that comes from Larry Coran's APA guideline for OCD, which puts the occasionally prescribed maximum dose. So it's always good to have this in your pocket if you're needing to justify what you're doing. We've had to come down with citalopram and escitalopram because of the QTC changes associated with higher doses, and suggest that you perform ECG monitoring if you're going to put these doses up. I still sometimes do increase these doses, but I usually monitor the ECG every 6 months to check the QTC is normal. But these are the doses that we would routinely use in our practice in the highly specialized clinic. And then there's antipsychotic augmentation, and this is David Veal's lovely recent meta-analysis looking at second-generation agents. Haloperidol does show efficacy when you add it in to SSRI. And of the compounds that seem to do better, we had risperidone and we had aripiprazole doing well. There was a little caveat. The studies of aripiprazole are small, and perhaps a little less reliable. So we really need better data for aripiprazole to support that finding. But on the whole, adding in antipsychotic to a treatment-resistant person on SSRI works. How does it work? People thought, oh, risperidone must be there. It's 5-HT2 antagonist effects. Well, possibly. This was a nice mixed model meta-regression that tried to plot the effect size in OCD of the adjunctive antipsychotic versus its binding potential to different receptors. And it was the potential binding to the dopamine receptor, the D2 and D3 receptor, that seemed to map onto the effect size in OCD, suggesting that it may be these drugs are working through dopamine. Though these are all different studies, these are not tested head-to-head in the same study, so there are caveats about that interpretation. And what about inpatient care? This is data from our other colleague, Lynn Drummond's unit at Springfield Hospital, showing you, these are the Y-box scores of people entering our inpatient services. Their Y-box is nearly 40. This is what we call catatonic OCD. These are people who can't talk, can't move, doubly incontinent. She was describing yesterday to us a case who was having to walk backwards up a railway line. I mean, these are life-threatening OCD cases. And with very intensive 6 months inpatient behavior therapy and medication, you can bring them down to about a 28. That's still pretty severe in your clinic, and so clearly treatment needs to continue, but there are gains to be made. People can survive with a Y-box of 28. It's hard to survive with a Y-box of 38. Moving on then briefly, how are we doing? Oh, we've got some time. To novel treatments and targets. Well, we've already had a lovely lecture about brain connectivity and systems within brains, and it's not just OCD, but most disorders in psychiatry have symptoms and cognitive deficits that can be conceptualized as disordered structure, connectivity, and function in these large-scale neural networks. In the case of OCD, it's this parallel circuitry that controls emotion, controls cognition, and controls motor activity that seem to be impaired. In the case of the affective loop, this was the first loop to be explored, and there's really very robust evidence suggesting that nodes within this system are dysfunctional in OCD. We have the ventral striatum connecting through subthalamus into the orbitofrontal loop. And dysfunction with this circuitry, to some extent, maps onto severity of OCD symptoms. This is the orbitofrontal loop, which has been the focus of neurosurgery for many years. But disruption within the dorsal striatum here links us into this cognitive control, the action selection circuit, and even through the putamen into the motor control and the habit circuitry, which we think are also very, very relevant for compulsive disorders. They're innervated by the ascending monoamine systems involving not just 5-HT, but dopamine and norepinephrine. And glutamate, we've heard about glutamate, is the primary neurotransmitter in the nodes within this network. So what treatments, looking at that circuitry, what treatments might work? Well, this slide simply summarizes all those small-sized randomized controlled trials showing a hint of efficacy versus placebo. And these are all again, repurposed compounds, if you like. I talked about ADHD. Here we have dexamphetamine in a single study. All these studies need replicating. These I would consider experimental treatments. We've got the opiate system working on the reward circuitry that I showed you. We've got ketamine. We've got one positive and one negative ketamine study in OCD, working on glutamate. We've even got a study of mirtazapine, acting on 5-HT receptors, perhaps. And then here we have aripiprazole is still a new compound on the block, so I've put it here because I think these are still quite small studies. Some evidence supporting mood stabilizers, lamotrigine acting on sodium channels, and also probably gating glutamate activity into pyramate. Memantine, which is possibly a more tolerable version of ketamine, acting as a partial agonist, antagonist at glutamate. 2 studies, again, small studies coming from Iran, looking at memantine. So again, all of this, in my opinion, needs to be replicated. Story of N-acetylcysteine, which is a cofactor in the glutamate pathway, some positive studies, but also some negative studies. So again, we're all hesitant. And granisetron, which is like a dansatron of 5-HT, 3 antagonist, small study showed it worked. But the large study run by the company Transept on odansatron, which gets through the blood-brain barrier better, did not work. So there may have been a problem with dosing here. Because this slide shows all those studies showing no efficacy against placebo. So these are things that don't seem to work. Bupropion, we thought doesn't. Naltrexone, it's good. I showed it for hair pulling, but it doesn't seem to work in OCD. Or maybe it does, just in a subset of OCD, and we don't know which ones. Agomelatine, I was part of a great study that didn't show any effect whatsoever. And here we have riluzole. Unfortunately, we thought riluzole, again, another glutamate compound, might work, but this is a study in children, and it quite convincingly showed that it didn't in that study. So where do we go next? Here's the circuitry again, and what are these little electric shocks? Well, they are just that. We're moving in desperation. We're moving to neuromodulation. The red is deep brain stimulation, and these are the targets that are being used. This is experimental, but it's current. And these are the non-invasive targets that are used now, either with magnets, transcranial magnetic stimulation, or direct current stimulation, direct cortical stimulation with like little machines like TENS machines. And the areas that seem to be effective is stimulation over the orbital prefrontal cortex and the motor cortex, or the supplementary motor cortex. So just to run through somatic treatments, ECT, just to remind you, doesn't seem to be effective in OCD. But there's a growing body of evidence that the non-invasive technique that's been used most in OCD is transcranial magnetic stimulation. It's not that convenient to do because people have got to go up to the unit and have this big magnet over their head. So it would be nice to look at these other more portable forms of non-invasive stimulation, but there's almost no data on them, so I can't really show that to you yet. Deep brain stimulation is a lot of interest. I've been party to one of those studies. The results seem to be fairly promising and match roughly the ablative neurosurgery results, with about half of the patients doing very well. Having said that, I mean, we haven't published our results yet. I would just simply say that deep brain stimulation, it is potentially reversible, but it's very effortful. Patients have to have a lot of input, a lot of tweaking of the currents, replacement of the batteries. You need high voltages for OCD, so batteries have to be surgically replaced after several months. So people will need follow-up probably forever on this. So it's not a treatment that you would offer lightly, and is quite costly for the NHS. This is a summary of the randomized controlled trials of transcranial magnetic stimulation in resistant OCD. And it's just to remind us, I mean, the effect size is really quite good. It's on a par with medications. But to remind you that it's not the dorsolateral prefrontal cortex, which is the target that you would use in depression and maybe binge eating disorder, but it is these other more OCD-related targets. It's the orbitofrontal cortex and the supplementary motor area that seems to give the best signal. So in conclusion, the treatment effect on SSRI is partial, it's dose-dependent, it's time-dependent. You can protect against relapse to some extent with long-term treatments. You may get better bangs for your buck if you put two treatments together. And I suppose my message is treat vigorously from the start, actually, because this is not a disorder that's going to go away. Our treatments are very limited, and we need new strategies. We need those endophenotype predictors. We need better handle on the circuitries. We'd love to have new compounds. We'd like new forms of psychological treatments that talk to the cognitive deficits in OCD. And there's a big question mark of the role of brain stimulation in this field. Thank you.
Thank you, Naomi. So we've got 5 minutes or so for questions. So, question down the front, and then there.
In a severe case of OCD, if the patient responds, how long would you recommend the treatment should continue for?
On medication?
On medication.
I don't think there's a good time to stop. So that's what I say. When I know when there's a good time to stop, I'll tell them. So indefinitely. There's the issue of pregnancy, of course. There aren't many other things that get in the way of usually SSRI treatments. Very often, if a woman is pregnant, they may need to remain on their medication through pregnancy, and we can manage that. You may just reduce the dose. My recommendation is usually to remain on medication long term.
Okay, next question here, and then after that we'll go back up to the fourth row from the back. Please go ahead.
Yeah, in my clinical experience in psychiatry here, clinical experience in psychiatry, I've seen quite a few patients developing OCD-like symptoms when they were on second-generation antipsychotic medications. Majority of them were on clozapine, but I've seen patients developing OCD symptoms with medication like quetiapine and olanzapine also. So the one which were on quetiapine and olanzapine, I managed to change them to first-generation antipsychotic. The symptom got better. And the one on clozapine, obviously, I had to add fluoxetine. But what is your experience with second-generation antipsychotic and patient developing OCD-like symptom with that?
I think it's just a really great question. The whole overlap between schizophrenia and OCD is very...
Sorry, Naomi, could you just repeat it for the audience, because they might...
Oh, right, you might not have heard the question. So the question is about obsessive-compulsive symptoms emerging in the context of treating schizophrenia with second-generation antipsychotics. That's correct, isn't it? And we certainly see a lot of obsessive-compulsive symptomatology in patients on second-generation antipsychotics, particularly those on clozapine. So if you run a clozapine clinic, we surveyed our clozapine clinic, and I think it was something like 30% scored high on a Y box for OCD. The question then is, well, is it the second-generation antipsychotic? Is it something pharmacological, revealing compulsive behaviour? Because we know there's a lot of compulsivity in schizophrenia anyway, and the compulsivity seems to map onto those disorders with a poorer outcome. Obviously, more treatment-refractory illness tends to be more comorbid, and of course it's those comorbid cases who end up on clozapine. So there's a concern that there may just be a bias, a sort of ascertainment bias affecting our understanding of this, as there haven't been any good prospective studies comparing head-to-head two different patients with schizophrenia on two different antipsychotics and looking at the emergence of obsessive-compulsive symptoms. So we can't explain it, but we observe it. There's been some limited data along the lines of your experience at switching patients from to drugs that have been chosen, a first generation or even aripiprazole, may actually be beneficial, but this is very low-level evidence. There needs to be a good trial. SSRI treatment of these patients doesn't tend to work that well. There's been one positive study, very small. Again, my clinical experience, lowest level of evidence, SSRIs aren't that effective in schizo-OCD. Maybe more mileage in behavioural treatments. We tend to forget that in our patients with schizophrenia. But sort of habit reversal therapies and behavioural treatments may work better than medication for them. So it's a really interesting area of overlap we don't understand.
Right, we're going to try and get 3 more questions in, so up the back and then down there. And Frank, did you have a question? And Frank as well.
Okay. Thank you for an inspiring lecture. In child psychiatry, I see a big link between OCD and other developmental disorders, particularly tic disorders, but also ADHD and autism. I worry, however, that sometimes stimulants seem to make OCD symptoms worse, and I wonder if you can comment about that.
Yes, so there's been a concern that stimulants like methylphenidate may certainly make tic worse and may possibly make OCD symptoms worse. Actually, in clinical practice, that's not often too much of a problem in my limited experience, but speaking to our colleagues who work in our national service, we do have colleagues working with child psychiatry cases, and I'm reliably informed that actually drugs like methylphenidate can be used quite effectively in a comorbid case. If you know, you may warn your patient that your tic might get worse, but actually it's not too much of a problem. So I would advocate considering adjunctive treatments with stimulants in those cases, monitoring them carefully. Obviously, if they don't tolerate it, then you haven't lost a lot. It might help hugely.
So we'll try and squeeze 2 more in.
Yeah. With regard to clomipramine treatment, if patients have ECGs and some minor forms of abnormalities like bundle branch blocks or borderline raise, QTC, and those kind of things occur, so cardiologists are not really interested, but psychiatrists are a bit reluctant to kind of then treat with clomipramine. What would you advise?
Well, I am cautious about the use of clomipramine and tricyclics. I think our patients are a pretty vulnerable group. So I would, if there are cardiac abnormalities, I would tend to err on the side of an SSRI. And I would take the irregularities seriously.
Okay. Frank?
My question is about lamotrigine and what we're actually treating. Anecdote, admittedly, very resistant obsessive-compulsive disorder, didn't respond to sertraline plus risperidone. Lamotrigine, the obsessions were still there, but absolutely not problematic anymore, absolutely transformed the life of the whole family, and didn't bother the person so much. Now, whether that's treating mood and reducing the effect of the obsessions, which were totally taking over the life of the teenager and family, or whether it's treating the obsessive-compulsive disorder, I don't know, but I'd really welcome any insight into what drugs like lamotrigine might do. They certainly can be life-transforming.
Absolutely, and I think when you get these small studies, one study shows an effect, another study doesn't show an effect, you wonder whether that there are different subgroups, subpopulations, some of whom might be more responsive to a particular group, and it's just at the moment chance as to whether you've picked that group of patients to test your drug in. In the case of drugs like lamotrigine, topiramate, these tend to have anti-impulsive effects. And I talked about the overlap between OCD and the more impulse-controlled disorders, the body-focused habit disorders, trichotillomania. These are very impulsive disorders. And it may be that there is a subgroup within OCD who have greater impulsivity, modified through the same or similar circuits, linked perhaps to, talks again to the overlap with bipolar disorder in OCD, that there may be a more disinhibited impulse control problem that the lamotrigine may be targeting, so actually affecting impulse control as well as compulsivity.
So we're going to try and squeeze in one extra. Lady there.
Hi, my question just kind of piggybacks onto what you were saying at the end there, and that's about when you get a patient with OCD and bipolar disorder together and how tricky that is. Any advice?
Lithium. Give them lithium. Well, Alan can tell me if I'm wrong. Give them lithium, mood stabilise them, and then you can put up the dose of SSRI. And usually they will tolerate a high dose of SSRI if they're mood stabilised.
Thanks.
Right, well, there's obviously great demand for questions, but thank you very much again, Naomi.